Welcome to this video on syncope. Syncope is a common, often worrying presentation. As residents, our job is to sort the benign from the dangerous. In this video, we will build a complete approach, from defining syncope to its causes, history, physical exam, and management. We will follow a single patient to keep our reasoning practical. Let us begin. Meet our patient, a 68-year-old man with hypertension and aortic stenosis. He fainted suddenly while climbing stairs. Note 3 critical features. It was exertional, there was no warning, and he has underlying structural heart disease. These are all red flags for a cardiac cause. Keep this case in mind as we build our framework. By the end of this video, you will be able to define syncope and distinguish it from its mimics. We will cover major etiologic categories, including reflex, orthostatic, and cardiac causes. You will learn to take a focused history, perform the right exams, and apply a formal algorithm and risk score to guide your treatment and counseling. Let's define our terms. Syncope is a symptom, not a disease. A sudden, transient loss of consciousness due to global cerebral hypoperfusion with spontaneous recovery. Distinguish this from sudden cardiac death, where resuscitation is required, and presyncope, which is near fainting without losing consciousness. Both require careful evaluation. Looking at the causes, nearly 40% of cases remain unexplained after a full workup. Reflex or vasovagal syncope is the most common identified cause and is generally benign. Cardiovascular causes account for about 20% of cases, but are the most dangerous, so our approach is specifically designed to identify them. Vasovagal syncope follows a clear reflex pathway. Increased sympathetic tone leads to vigorous ventricular contraction. This stimulates stretch receptors, triggering a surge in vagal tone, which drops both heart rate and blood pressure. Common triggers include pain, fear, or situational events like coughing or urination. Carotid sinus hypersensitivity works via this same pathway. Orthostatic hypotension occurs when the body fails to maintain blood pressure while standing. Common causes include volume depletion, deconditioning, and medications like vasodilators. Younger patients may experience POTS, a specific dysautonomia. Always check for underlying autonomic neuropathies, both primary, like Parkinson's, or secondary, such as diabetes or alcohol use. Arrhythmic syncope is challenging because the arrhythmia is often transient and resolved by the time you obtain an ECG. We categorize them as bradyarrhythmias, such as AV block or drug-induced slowing, or tachyarrhythmias such as ventricular tachycardia. Remember that SVT rarely causes syncope unless there is underlying structural heart disease or WPW syndrome. Mechanical or obstructive syncope is a fixed blockage to cardiac output, often triggered by exertion. This includes endocardial issues like aortic stenosis, myocardial problems like hypertrophic cardiomyopathy, or vascular emergencies. Pulmonary embolism is a critical diagnosis to consider whenever no other cause is identified, especially in patients with high-risk presentations. Neurologic causes are less frequent. True neurologic syncope results from impaired blood flow, such as in stroke or dissection. It is vital to recognize mimics, seizures, hypoglycemia, or psychogenic events, which cause loss of consciousness but are not true syncope. Labeling them correctly ensures the patient receives the appropriate diagnostic workup. The foundation of your evaluation is simple: the history, the physical exam, and checking orthostatic vital signs. These provide the highest yield. Your primary objective is to rule out life-threatening causes, like cardiac arrhythmias, severe blood loss, pulmonary embolism, or subarachnoid hemorrhage. Once those are excluded, you can move forward with more confidence. The patient's story is your best diagnostic tool. Exertional syncope points to fixed obstruction. Fainting upon standing suggests orthostatic issues. Typical vasovagal triggers include pain or heat, while situational triggers like swallowing or coughing point to specific reflex pathways. Head turning suggests carotid sinus sensitivity, while arm exercise might indicate subclavian steal. Pay attention to the onset. A sudden event with no warning is a cardiac red flag, as the heart provides no time to react. Conversely, a prodrome of nausea or lightheadedness often indicates a vasovagal process. Always ask about associated symptoms like chest pain, palpitations, or postictal states, but be careful not to mistake brief, benign convulsive activity for epilepsy. Reviewing past and family history is essential for risk stratification. Patients over 35 with known heart disease, a history of atrial fibrillation, or cardiovascular symptoms are at higher cardiac risk. Note any syncope that occurs while lying down or during exertion. Family history of sudden cardiac death or cardiomyopathy provides important clues, even for presumably benign cases. Finally, always perform a thorough medication review. Many common drugs, vasodilators, diuretics, and negative chronotropes, can lower blood pressure or heart rate and precipitate fainting. Proarrhythmic drugs, or those causing QT prolongation, along with various psychoactive substances, are frequent contributors. Check the list carefully to identify reversible causes in every patient. Now let's look at key exam maneuvers. Orthostatic vitals are positive if blood pressure drops significantly, or if there's a rise in heart rate when standing. Check blood pressure in both arms. For suspected carotid sinus hypersensitivity, perform a gentle massage only after confirming the absence of bruits. A positive result is asystole, or a major pressure drop. Complete your exam by checking for cardiac, vascular, and neurologic findings. Look for heart failure signs, murmurs, or ventricular hypertrophy. Check for asymmetric pulses or bruits, which influence whether you can perform carotid massage. On the neuro exam, look for focal findings, tongue biting, or incontinence, which may suggest a seizure instead of syncope. Obtain a 12-lead ECG for every patient. While it rarely identifies the cause definitively, it's cheap, fast, and vital for catching dangerous rhythms or structural clues. Scan the tracing for conduction delays, signs of arrhythmia, or evidence of ischemia. It is an essential step that must not be skipped in the evaluation of any syncopal event. Laboratory testing should be targeted. Check glucose and hemoglobin. Get a pregnancy test for premenopausal women. Use a D-dimer only if you suspect a pulmonary embolism. An echocardiogram is the essential test to rule out structural heart disease like cardiomyopathy or valve issues. Reserve the tilt table test for cases where the initial workup remains unrevealing. Choosing a rhythm monitor depends on symptom frequency. A Holter is for daily events. Event monitors are patient-activated and useful if there is a warning. Loop recorders and mobile telemetry provide longer windows for capturing elusive arrhythmias. For recurrent but infrequent syncope, an implantable monitor is often the best tool to establish a definitive diagnosis over time. Advanced studies are for specific indications. Use exercise testing or coronary angiography for exertional syncope to rule out ischemia. Electrophysiology studies are reserved for high-risk patients with suspected arrhythmias. Cardiac MRI helps diagnose sarcoidosis or arrhythmogenic cardiomyopathy. Only pursue neurologic imaging or EEG if your history and physical exams strongly suggest a primary neurologic cause. This algorithm guides our next steps. Your initial evaluation, history, physical, and ECG will place the patient into one of three buckets: diagnostic, suggestive, or negative. A diagnostic finding provides an answer. A suggestive finding guides further targeted tests. If the initial workup is negative or suggests a cardiac cause, we proceed down the cardiac pathway. The cardiac pathway is critical. If your initial workup is negative, but the clinical picture is concerning, like exertional syncope, prioritize an urgent echocardiogram. The echo will categorize the patient's mechanical heart health. If it's normal, focus on ambulatory monitoring to capture any occult arrhythmias. This step-by-step approach helps ensure you don't miss life-threatening pathologies. Risk stratification determines who needs admission. Admit with telemetry if you see red flags. Advanced age, history of heart disease, exertional syncope, or a concerning ECG. The Canadian Syncope Risk Score is a helpful tool here, as low-risk patients with no arrhythmia in the ED have an extremely low chance of a serious event in the next month. Treatment for reflex and orthostatic syncope starts with lifestyle changes. For vasovagal events, teach trigger avoidance and counterpressure maneuvers. For orthostatic hypotension, focus on hydration, increase salt intake, and rising slowly. Medications like midodrine or fludrocortisone can be added if lifestyle measures are insufficient. A pacemaker is rarely indicated and is reserved for specific, severe cases. For cardiac and mechanical causes, treatment is focused on the underlying disease. This might involve valve intervention, revascularization, or rhythm management. For specific high-risk conditions like cardiac sarcoidosis or Brugada pattern, consider an implantable cardioverter defibrillator. The priority is always to treat the primary pathology responsible for the syncopal event. Prognosis depends on the cause. Idiopathic syncope has a relatively low recurrence rate, while cardiac syncope carries a significantly higher risk of mortality, necessitating aggressive management. Always conclude by counseling patients on safety, including driving laws and high-risk occupations. Your guidance helps patients manage their condition safely while living their daily lives. Returning to our patient, his exertional syncope with known aortic stenosis is a high-risk cardiac presentation. Our plan is to admit him with telemetry, get an urgent echocardiogram to quantify his valve disease, and ensure a cardiology consultation. By following this systematic approach, we ensure he gets the definitive care he needs to prevent future events. To summarize, syncope is a symptom of global hypoperfusion. While often benign, you must always rule out cardiac causes. Your history, exam, and ECG are your best tools. Always identify red flags, admit high-risk patients, and tailor your treatment to the underlying diagnosis. This simple framework will serve you well in clinical practice. This approach is informed by major cardiac guidelines and landmark studies. Please be sure to review these primary sources and verify all clinical information with your local team and subject matter experts. Thank you for watching and building your approach to the evaluation of syncope. This topic connects to another video in this series. In a moment, a clickable thumbnail will appear on your screen. Click it to access the associated video, where we build further on what we've just covered. You can also find it linked in the description below. Thanks for watching, and I'll see you in the next lesson.